Tengan ustedes muy buenas tardes y sean bienvenidos. El día de hoy vamos a hacer partícipes
Tamam. Urinary. Katatam.
Cigarette. Cuba.
Ok, César.
Hola, ¿cómo
Estamos
estás?
probando
¿Cómo estás?
cámara, voz.
Perfecto. Good morning, Dr. Johanny. Good afternoon en Finlandia.
Sí.
Oh, hello. Good
Hello.
morning there in Peru.
Thank you very much.
¿Se escucha bien la voz?
Se escucha perfectamente. Perfecto está. Está mejor que la vez anterior de la prueba.
Para que pueda delinear.
Okay. Hyvä. The voice is good, right?
Okay.
La voz es buena.
La voz es
Dani,
perfecta de ambos.
de ambos, ok.
Perfecto. Se ve y se escucha muy bien.
Son hyvä. Son kaikki. Joo, kiitos paljon. Kiitos, oli se hyvä. Joo, ok, podemos ir ajustando. Ok, ¿cómo es? We are going to talk in English in order to, to coordinate. We are, it's supposed to be exactly 8 o'clock Peruvian hour, isn't it?
Así
8
es.
o'clock, yeah.
Empezamos a las 8 en punto. Sí, yo voy a dar primero unas palabras muy simples de presentación.
Sí.
Y ya está aperturado el Zoom, ya están ingresando, hay 12 personas ahorita.
Sí.
Y van a ir ingresando paulatinamente. Y luego de eso, luego la presentación, empezamos inmediatamente.
Perfecto.
La temática va a ser la siguiente.
Sí.
El doctor va a hacer las 3 presentaciones. Hoy toca hombro,
sí.
hombro, codo, rodilla y cadera. Entonces,
sí.
de acuerdo al programa, ¿no?
Sí.
Al final, vamos a ver las preguntas, ¿no? Las preguntas y una pequeña mesa rodando, una cuestión máximo será de 25, 20 minutos, de acuerdo a las preguntas, ¿no?
Yes. Okay.
Y ahí culminamos la sesión del día de hoy, ¿ya?
Okay. Perfecto. Kalau siko también puhun englantia vai suomeksi voi olla
Milloin?
molemmat, mennään kommunikaatio, voi olla suomeksi.
Tarpeen mukaan.
Joo, tarpeen mukaan. Joo. Eli hän kerroi, että tänään on kaikki suunnitelman mukaan, tämä kaikki luento, joka on suunniteltu. Alussa hän tekee joku pieni muutama minuuttia, se on introduce.
Ja.
Ja sitten että sen jälkeen sun 3 luentoon ja loppuvaiheessa tulee kysymyksiä ja ehkä pieni paneeli, pieni keskustelupaneeli, joka tulee. Se on, siis ei mitään editystä. Okei, perfecto. No hay ningún problema. Yo creo que es más o menos acorde con lo planificado.
Sí.
No es necesario, pero si tú quieres... Okay.
Se les escucha y se les ve perfectamente, o sea que ahí no hay ningún problema.
Perfecto. ¿Cómo está el clima how is the weather in Lima? How is the weather? Is winter time?
Claro, ha habido, este invierno ha sido para nosotros, para ustedes, te vas a reír, pues con 15 grados que hace frío acá en Lima, ¿no? Este invierno ha sido ha sido intenso, ¿no? Ya está saliendo el solcito de primavera, ¿no?
Yes, actually,
Ya está entibiando las mañanas de Lima, ¿no? Que como te digo, el invierno ha sido frío.
and starting the spring en Lima. Perfecto.
Así es.
Bueno, qué bien, Cecita. Estamos, gracias a Dios, todas las cosas acá respecto a la planificación han salido bien. No hay creo que no va a haber ningún tipo de contratiempo,
Sí.
ningún tipo de percance.
Sí, al inicio es así, pero ahora esto del Zoom es una maravilla, pues es una maravilla, ¿no? Como te digo, en la Sociedad Peruana de Radiología hemos tenido varias conferencias y han salido, pero perfectas, ¿no? Por eso es que nos animamos y gracias a tu gentileza, ¿no? Gracias a tu gentileza,
No,
tener a un experto como el doctor Yuhani y que va a ser muy importante estas charlas porque nosotros conversando ahí en el departamento, hay un grupo de radiólogos entrenados en ultrasonido musculoesquelético, ¿no? Gente joven, pero básicamente con la escuela norteamericana, ¿no? Entonces, tenemos mucha relación con los reumatólogos de nuestro hospital, el doctor Armando Calvo, y todo el grupo de trabajo siempre han estimulado a que en nuestro departamento se desarrolle, ¿no?
claro.
Entonces, yo recuerdo, más tarde va a estar el doctor Calvo, cuando vio una de las primeras ecografías que hice de mano, me dijo, César, habíamos estado ciegos. Cuando vio la hipertrofia sinovial ahí, ¿no? Entonces, ellos organizaron un curso ya hace 4 años con dos reumatólogos chilenos afincados en Estados Unidos.
Sí.
Y me invitaron, yo estuve con ellos y fue muy importante, ¿no? Un aprendizaje de 1 semana estuvimos en ese curso.
Ya, espérame, voy a traducirle. He said that 4 years ago was the first meeting with a couple of Chileans rheumatologists who get training in USA, and was the first experience in rheumatology, in the ultrasound rheumatology in Peru. They don't have some, even though they have more related with the American school, they are more related, and also Cesar was making the fellow in USA, and they are more familiar with the USA. But this is the experience of the department. Okay, seguimos.
Claro, y quiero que eso le enfatices al doctor. Los radiólogos estamos acostumbrados a ver tendones, ¿no? Tendones y tendones, desgarro, pero muy pocos, ¿no? Por eso es el objetivo de este curso, le damos importancia a lo que ven los reumatólogos, ¿no? Y eso nos decía el doctor Calvo.
Joo, heillä on paljon kokemusta jääneistä, ei samalla tavalla tämä reumatologia varmaan. ¿Tú te refieres a tendones en relación a traumatología, lesiones agudas?
Ajá, así es.
De medicina del deporte, ¿no? De medicina del deporte.
Así es, de medicina del deporte,
pero
de
no así
traumatología.
tanto en reumatología.
No tanto de la relación con reumatología, y eso es lo que nos indicaban los reumatólogos, ¿no? Queremos ver la bursa, ¿no? Hazle Doppler, ¿qué grado de inflamación tiene? Mira, este es un panus, pero terrible, quiero que me digas si hay actividad o no hay actividad, ¿no? Entonces, esa ha sido una constante interacción y eso es importante, ¿no?
Yo creo que es excelente. Estas conferencias van a ayudar mucho. Voy a traducir, ¿no? They say that they don't have so much experience and they more focus. Parempios minä puhun suomeksi on helppo. Eli se on hänellä on joku tämä urheilulääketiede enemmän ja myöskin traumatologia orientoitunut tämä. Ja sitten, että Muta reumatología on palion Asia yo camela yo Perus Asia Ilio Perus Asia.
Doctor, esto no es inglés.
¿Cómo está, doctor Galloso? Buenos días.
Armando.
Doctor Calvo, ¿cómo está? Buen día, qué gusto de saludarlo. Lo presento al doctor Jesús Santisteban, él es médico peruano, pero muchos años radicado en Finlandia, es de mi promoción de la vieja escuela de San Fernando. Y él tuvo la gentileza de contactarnos con el doctor Yuhani, está el doctor Armando Calvo.
Doctor Calvo, gusto
Nice
de
to meet
conocerlo.
you.
Good morning.
Calvo.
Good morning.
Pleasure.
Oh, nice to see you. Yes.
I am a rheumatologist.
Yeah, actually, sorry, you are Dr. Calvo, isn't it?
Yes.
Sí, el doctor Calvo.
It's Oscar Galloso.
Sí, es el celular del doctor Galloso.
Okay, sorry. Yes, okay. Glad to meet you. Let me introduce the former chairman of our department, and Dr. Juhani Koski. He's one of the most, perhaps in Finland, the most relevant, important ultrasound trainer in the whole Finland.
Well, thank you.
Dr. Calvo is the former chairman of the Department of Rheumatology, or one of the most important, relevant also professors in the university.
Okay.
Ujú.
He's a rheumatologist.
Rheumatology.
Sí, sí.
Doctor Calvo, usted es actualmente el jefe del departamento de reumatología de la universidad.
No, la universidad no tiene jefe de departamento, no.
Ya.
No ha abierto un departamento de la universidad.
Ya.
¿Cómo está? A ver.
Ha sido jefe del departamento de reumatología del hospital.
Y de medicina.
Y de medicina, ¿no? Durante muchos años, ¿no?
Qué bien, qué bien.
Sí.
Yo cuando era estudiante roté con el doctor Subaste, hice un pequeño externado en el OAISA, y realmente el doctor Subaste fue una de las personas que me inspiró mucho en medicina interna y reumatología, ¿no?
Claro, qué bien, sí, muy importante el doctor Subauste para la medicina peruana.
Sí. Yo soy cuñado de Napoleón Chávez también, y soy primo hermano de Oscar Frisancho, que son de Cayetano, muy cercanos a su promoción.
Ajá. Sí, Napoleón Chávez, yo también lo conozco. Y Frisancho está pues en Puno, ¿no? ¿O está en...
No, él falleció, Oscar,
Oscar.
gastroenterólogo.
Ya.
Sí.
Así es, doctor Calvo, le estaba contando la pequeña historia que tenemos de amistad con reumatología y radiología, y sobre el énfasis que ponía usted para los exámenes. Recuerdo que me traía esos casos de los panus andante y me pedía, pues, ponle Doppler, quiero ver si hay actividad, ¿no?
Necesita, creo que estamos casi a 2 minutos de empezar.
3 minutos.
Estamos a
Sí.
las 8 en punto.
Así es.
Okay, we are going to start just 8 o'clock. We have almost
2 minutes.
2 minutes.
3 minutes.
Okay, we are almost ready. Giovanni, puhutaan parempi suomea, minä luulen.
Okay.
Puhutaan parempi suomea.
Okay.
Perfecto. Entonces, Omar, a las 8 en punto, por favor, pones el tríptico del curso. Doy unas palabras y lo presento al doctor y empezamos.
Ok, doctor.
Gracias. Omar es el técnico de la universidad que nos está apoyando.
Perfecto, gracias.
Faltan 2 minutos.
Ya, listo. Tan pronto llega alguien de acá, yo les paso la voz.
¿Y allá qué hora es, ah?
Las 4 y...
Van a ser las 4 de la tarde.
4 de la tarde.
Estamos bien.
Sí.
Ya, listo para decirle.
Por favor, sí, vamos a agradecer que todos tengan el audio apagado, por favor. O si no, Omar, iniciamos la conferencia y apagas el audio a todos. Gracias.
Ok, doctor.
Muy amable.
Minä kanta, joka alussa tuli muutamia sanoja sinulle.
Okay.
Muy buenos días, tengan todos ustedes. Doctor Yuhani Koski, doctor Santisteban, doctor Armando Calvo y todas las personas que nos acompañan. Vamos a dar inicio a nuestro curso de ultrasonido musculoesquelético. Tenemos en el auditorio a médicos radiólogos, reumatólogos y residentes de ambas especialidades. Estos 3 días vamos a hacer una revisión de la técnica de estudio de las diferentes articulaciones del aparato locomotor, enfatizando en las principales patologías de las enfermedades articulares, donde el ultrasonido ha demostrado su valor importante. Nuestro agradecimiento al doctor Yuhani y especialmente al doctor Santisteban, viejo amigo de las aulas sanfernandinas, con quien hemos realizado y programado este curso, que hoy se hace realidad. Asimismo, nuestras jornadas heredianas de ultrasonido también es un homenaje al 60 aniversario de la creación de nuestra casa de estudios. El programa del curso está dividido en 3 días. El primer día, el doctor Yuhani nos hablará sobre la ecografía del hombro, la técnica, que es importante, el codo, la rodilla y la cadera, enfatizando los aspectos técnicos. Al final de las exposiciones, se realizará un round de preguntas y una mesa redonda con la participación de nuestros invitados. Muchas gracias. Dr. Yuhani, Dr. Santisteban, good morning. Good afternoon in Finlandia. We are going to start our musculoskeletal ultrasound course. We have radiologists, rheumatologists, and residents of both specialties in the auditorium. This is 3 days. We are going to review to study technique and different joints of the locomotor system, emphasizing the main pathologies of joint disease. Our thanks, Dr. Yuhani, and especially Dr. Santisteban for his support that this course has been carried out. Our Radial Ultrasound Conference is also tribute to the 16th anniversary of creation of our university. This course program is divided in 3 days. The first day, Dr. Yuhani will talk to you about ultrasound of shoulder, elbow, knee, and hip, emphasizing in the technical aspects. At the end of the exhibition, there will be questions around table with participation of care guests. Thank you so much.
Yes.
Okay, thank you very much.
Thank you very much. Okay, you can
Yeah, okay, welcome on my side to this 3 days course. It's online course, and it's a pity we cannot make hands-on sessions. Of course, it could be a little bit difficult, but so this course is online and theoretical, of course. But I hope that my slides are representative and nice to follow. I try to speak fluently and in English. Spanish language is one of the most important in the world, but sorry, I cannot speak that. Sorry, I speak in English. Shall we change the screen to the presentation?
Yes.
So let's start with the shoulder.
Okay.
Then here, like that, and then it was like that, and then like that. Great. How can I put this away? Okay, fine. Do you see the slide? First slide.
Miran bien la diapositiva.
Ultrasound.
No se ve.
Okay.
No se ve. No
Perdón,
se ve.
No se ve.
Tiene que
No, no.
compartir la pantalla.
Sí.
Ah.
We have to share. We have to share the.
Okay. Yes.
Eh,
Launch meeting. No.
Coquele.
Share
Launch.
screen.
César,
No.
tienes que dejar de compartir tú.
Hold on, please.
Omar, dale
Okay.
la...
Okay.
este,
Share
Share
me.
screen, yeah.
Share the screen.
El screen en
Great.
la parte inferior, doctor.
Share.
Sí, share
Okay.
screen.
Biela. Onko
Yeah.
jostava.
Not this one.
Sama ja se.
Okay,
Ahora sí.
Okay, fine. You see this?
okay.
¿Se ve bien?
Very good. Se ve
Okay.
bien y se escucha bien.
Yes, but now I have to change the screen and then make
The large
once
screen.
again. And then it was like that. And
Okay, very good.
okay, now you see the first slide, ultrasound of the shoulder.
¿Se ve bien todo la
Excelente.
imagen?
Okay,
Se ve bien y se escucha.
I put it
Excelente.
away? I think this is not relevant here. Yes, here. Great. You hear my voice?
¿Se escucha bien mi voz?
Se escucha perfectamente y se ve perfectamente.
Now, fine, we go on.
Let's start.
So the first slide, ultrasound of the shoulder. Let's have a look at the bony anatomy first. There are some important palpable aspects like corax here, attachment of many muscles, pectoralis minor, coracobrachialis, and of course the short head of biceps. We have clavicle here, acromioclavicular joint, lesser tubercle, attachment of subscapularis, and of course intertubercular groove here, and the greater tubercle attachment of supraspinatus. Many of these we can palpate. This is the cartoon of relevant anatomy. When we take the skin and subcutaneous tissue away, we see the deltoid muscle. And if we take this away, deltoid muscle away, we can see important structures of rotator cuff, supraspinatus here. Then we have subscapularis, and I will show in a minute the posterior view. But here we also see the biceps tendon, the long head attaching to the glenoid, and this short head of the biceps attaching to coracoid process. Okay, pectoralis major is important to stabilize the long head of biceps. It goes around the tendon and attaches, makes more stable this biceps structure. Then we have the posterior view. If we take the deltoid muscle away, deltoid is attaching to the scapula and acromion. We take this away, we see infraspinatus, which is not very often involved in rotator cuff disease, but of course it's an important structure. Under that, teres minor, which is there is not very much pathology in cases of rotator cuff. And here is, this is not the rotator cuff, this is teres major attaching to humerus, but it is shown here also. In this slide, we can see simplified standard scans of the shoulder, how to depict biceps in transverse, in longitudinal, and Persa 2. Subscapular is best depicted turning the arm outwards and inward, outwards, yes, in short axis, in long axis. And then we have this so-called crash position depicting supraspinatus. We put the hand on the back of the patient. So then we can depict also from the lateral point of view, bursa and deltoid muscle. And then the important posterior oblique scanning for infraspinatus and the joint itself. Joint can be reached also using axillary scanning, but this is quite rare. Usually I depict joint using posterior oblique view, and AC joint of course too. We will see in next slides more detailed these structures. Here I'd like to advertise EULAR website. There is a very nice and good site here for all. It's for free, and you can, it is just put on Google EULAR ultrasound scanning app or something like that, and you can see this portal, and there is a normal anatomic and scanning technique for all joints. This is very, very good, and made by Ingrid Möller, who is Spanish. The name is Norwegian, but because her father was Norwegian, but and many other have done this website. There are, for example, more than 100 images and videos of the shoulder. So this is only for normal technique. There is also in World Wide Web structures and for abnormality, but I will not go through this list because we will have a slide for every pathology. So why to use ultrasound in evaluation of the shoulder? Simply because the anatomical alteration is difficult to detect. We can palpate and see the structures and some pathology, but it's difficult. And there is also scientific data that the correlation is poor between clinical findings and anatomical abnormalities. And especially this rotator cuff degeneration is relevant factor in loss of function and force in rotator in shoulder. So it is difficult, and ultrasound gives a lot of nice information for daily practical life for rheumatologists as well as for radiologists. Inflammatory shoulder, there are many causes like rheumatoid diseases, spondyloarthropathies, OA, osteoarthritis, crystal arthropathies, post-traumatic synovitis, polymyalgia, septic arthritis, tuberculosis, and so on. In adults, the inflammatory and degenerative changes, they are mixing. This column here is for inflammatory shoulder, and this is for degenerative shoulder. And as you see, many things overlap. For example, we can have glenohumeral joint synovitis. It may cause rotator cuff tear, but on the other hand, if we have a degenerative shoulder, rotator cuff tear is related with effusion. So if you see effusion, you don't. It's sometimes difficult to say, is this because of inflammation or is the primary reason rotator cuff tear? The same is with biceps effusion. You can say that there is tenosynovitis, but in rotator cuff tear, you can also find biceps effusion. The same is with subdeltoid bursitis. It might be inflammatory, but there might be also a rotator cuff tear, which causes subdeltoid effusion. And finally, bone erosions. Are they specific for inflammatory shoulder? No, because also, especially in old people, there are bony irregularities. They are very common, and as we can see. So let's start with the biceps tendon. The hand is placed like this. And in normal case, you see the bicipital groove, and the corresponding ultrasound transducer position is like this. And here is the cartoon. In mild tenosynovitis, you might see a little bit fluid. What is relevant? What is excess of fluid? Nobody knows. This could be normal too, but well, there is a little bit effusion. But in this image, yes, there is definitely obvious tenosynovitis. So a lot of fluid around the tendon. Here I highlight our enemy number one, anisotropy. It is, in this case, ultrasound beam comes exactly in 90 degrees angle to the tendon. But if you tilt the probe just 1-2 degrees, it's black. So this is in all aspects when we are depicting with ultrasound the same. You should always be sure in two directions, or is this fluid, or is the groove empty, or is it normal? The enemy number one in ultrasound is anisotropy. So let's go on. Biceps tendon should be scanned also in longitudinal way, like here, the position of transducer. And this is what you should see. Fibrillar typical pattern, and if there is effusion, you see it here. In this panel, you see tenosynovitis, a fluid around the tendon, but also bursitis. So this is longitudinal scan as depicted in this photo. In case of tenosynovitis, Doppler is also helpful. If you see this grayscale image in long axis of the tendon, it's difficult to say that this is normal, but if you push the button and see the vasculature, the circulation, this is too much. This is not normal. There is too much vascularity around the tendon. The corresponding transfer images are here. So we will talk in later more from Doppler, but it just shows the vascularity, and this is common in inflammation. In evaluating biceps tendon, we use always some movement of the shoulder to show is it steady, is it in the groove, or does it move? For example, if you look this image, you might think that the biceps is here, but wrong. It's here. I will show you in this video, and this means that the so-called biceps cable is broken, that the tendon can slip, go around here. You see, it's here. This is quite tricky, that there is a dislocation of biceps tendon, and you can see it when you move, abduct or rotate the shoulder. And then the biceps tendon rupture. When we have this total rupture, it's clinical. The Popeye the Sailor hand. This is, but also you find so-called empty groove with ultrasound, and in long axis you don't find this fibrillar structure, and in this case even there is absence of the stump can be seen here, the stump of the tendon. Subdeltoid bursitis. Normally in short axis like here, transverse bursa can be seen as 1-2 millimeter space between deltoid and supraspinatus or rotator cuff. So, but in case of fluid, there is more or less anechoic material between deltoid and rotator cuff. In this case, the bursitis is chronic. There is vascular phenomenon here, and this is not anymore fluid. This is more or less echogenic. There are proliferation here in the space. Here in this video, I hope you can see the video. There is moving circulation. There is fluid and echogenic material in the very big bursa depicted in long axis, and there is vasculature. So this is typical rheumatoid large bursitis. This was not anymore related to that. The detection of acromial subdeltoid bursitis, it's very sensitive and specific. According to Eva Alasaarela, who is a retired rheumatologist, made a nice thesis. He examined this sensitivity and specificity of ultrasound for detecting of shoulder disease against surgery. And if we see a swollen shoulder, in most cases, that means that there is a subdeltoid bursitis. Okay. This is only a rare case of mine in one man with high CRP, and he had a painful shoulder. He had in deltoid muscle around it mixed echogenic structure with Doppler signals in long axis, and when I put a needle into that lesion, bus were taken out, Staphylococcus aureus. That was quite an uncommon finding. Now, subscapularis is attaching to the lesser tubercle. You can scan it in this way, in longitudinal scan, and in this case, it is obligatory to make outward rotation like this. This is biceps, and here we can have a look at this biceps. All this is the subscapular. So you have to make outward rotation. You can also scan it in transverse view, and then with new technology, you can easily see these so-called bundles in the subscapular tissue. This muscle is not homogenic. It's there are bundles of muscle going, but so that just in case you are wondering what they might be. Subscapular area is not very common for pathology, but you might find tears. Here is a minor tear in subscapular muscle, exactly in this area of the cartoon. But very common finding is to find, especially in elderly people, calcification and bony irregularity. But these tears, especially total tears, are quite uncommon in subscapularis. Acromioclavicular joint is normal, depicting, but here in effusion there's widening of the joint area, and in case of osteophytes you might find this also. Then sternoclavicular joint, I find it most easy to scan when patient is in supine position, and in case of synovitis there is mass, mixed echogenic mass in the joint. Here is one example of acromioclavicular joint inflammation, grayscale Doppler image, and MRI of this very same patient. Now, the most important muscle is supraspinatus, because in human body it is very often broken, especially in elderly people, but in athletes too. And in ultrasonography, we depict it in grasp position, putting the hand on the back, or modified grasp position if the patient cannot put the hand on the back. Remember that when the patient puts the hand in grasp position, this muscle and tendon comes in front of the patient. So we are actually depicting this lateral tendon in front because of this position of the hand. And if you see this kind of eagle's beak, you can be quite sure that there is quite normal situation. And now also the transverse scan. This is very important. You depict it so that you go from medial to lateral, from lateral to medial. The transducer should be raised upward, downward, and scan the whole cuff, trying to look these holes, total rupture or partial ruptures. What is rotator cuff tear? Full thickness tear is hypoechoic defect. Hypoechoic means black. Longitudinal view, transverse view. There is a defect here. This is one criteria. The second criteria is non-visualization of the cuff. If you don't see this eagle's beak, if you don't see it, you try to find it, you don't see it. So you can be quite sure that there must be huge rotator cuff, full thickness tear. And according to literature, according to Cochrane database, MRI and ultrasound are quite similar for detecting rotator cuff tears. Of course, you must be familiar with ultrasound and you must have equipment which is reliable. Rotator cuff partial thickness tears are not so easy to recognize. The partial thickness tears might be on the bursal surface, in the substance intratendinous, or under so-called articular surface. But these are not easy all to see. Sorry, I think that my title is obscured by it says here supraspinatus tendinosis. It means a deterioration of the tendons, collagen due to microfracture or tendinitis. What is this? It's a thickened tendon with mixed echogenic structure. It's something different than on the normal side. What is this? My opinion is that this might be old tears with scar tissue or something like that. It might be related to cuff tears happened earlier. Calcifications we can also depict. We can also see these in X-ray, but with ultrasound. And in this case, the calcification is so thick that ultrasound beam cannot penetrate it. That's why we don't see anything under the calcification. But in this case, this is a flickwick calcification. We can see it through the calcification, and this is not quite common, but in this case, it could be possible to aspirate this calcification, but this is another story. Infraspinatus, not very much pathology in this area, but sometimes in this case I have found some calcification in infraspinatus insertion. Teres minor, again, not very much pathology found in teres minor. You can see teres minor putting the probe on the spine of scapula and coming down. You see under deltoid infraspinatus, and then next muscle under infraspinatus is teres minor. You can follow it to the insertion of humerus. And now, important for rheumatology is the posterior scan of the joint. In normal joint, there is in the corner of labrum, humerus, and infraspinatus, there is not fluid here. But in case of fluid, and you move the hand or the shoulder outwards, you can see hypoechoic fluid. Not much, but you can clearly see that there is fluid. This is a nice trick to get better visualization of the fluid. In chronic arthritis, you might find also Doppler, but this is not, I think, nowadays when we have very good treatments, not very common anymore. But you can see a thickened widening of the joint space with proliferative changes and Doppler signal. But this is not very common. And then the axillary ultrasound. It resembles very much the hip joint scanning, but we will come on that later. In case of fluid and synovitis, this bone capsule will widen this space. Actually, in axillary area, there is a loose area here, and in case, because of gravitation, fluid comes down and can accumulate here in the axilla. But this is not very common to depict. What is the most sensitive way to to scan this. It is this dorsal scanning we saw in the first place, but also axillary system is quite good. Validity of ultrasound in detecting of synovitis is high. According to Eva Alasaarela's studies, ultrasound, the correlation is very good, and the correlation to surgery too. And also, so the reliability is quite good. And now this slide is for those doctors who if you are interested in somehow in ultrasound of the shoulder, but don't want to do it very thoroughly, carefully. So just remember that do this movement. When you do that movement, you might find biceps tendon effusion and subdeltoid bursitis. Usually you find it when you do that movement. Then change your probe to the posterior area and find the effusion. So in a few seconds, you can see, is the shoulder wet or dry? But if it's wet, you should evaluate the rotator cuff too. But just to check, is there some findings of inflammation? Then cortical erosions. These are white, clear. They are intra-articular discontinuity of the bone surface visible in two planes. Old definition. Ultrasound is more sensitive than plain radiography, but MRI is more sensitive than ultrasound. But when we take very small erosions, ultrasound has better resolution in small erosions. This is an example of MRI plus ultrasound in the same patient. You see here erosions in T1 weighted MRI and the corresponding ultrasound erosions. Usually you have to scan dynamic way to find these erosions. For example, now you see a clear huge erosion found when I rotate the shoulder. But don't forget that also these cortical irregularities can be found very often, especially in healthy old people. Here we see an example. You see very clear, it resembles erosions, but are not quite that deep, but very common. In 25% of old people, you may find. Then impingement, subacromial impingement. If you abduct the hands, the supraspinatus, so the transducer is here is acromion. It's placed like this, and this supraspinatus should go under the acromion. But in case of impingement, it doesn't go. Patient says it hurts, and there is fluid in the bursa here, a little bit fluid, and he or she cannot get the tendon under the acromion. So there must be impingement. But impingement can be found in anterior area too. Here is coracoid process, subscapularis, and pay attention to this area. What happens when the patient is rotating the hand? There is clearly some impingement here. in this. I put my hand here. I felt clear knock there. There was some impingement between subscapularis and coracoid process. Reliability of ultrasonography has been investigated by doctors. There were 14 observers, examined 5 patients in 2 rounds, and compared with MRI, and it was shown that the reliability of ultrasound in depicting shoulder was good. In most shoulder pathology in RA. So this was the end of the first lesson. This is one of my grandchild, a typical Finnish summer view. We were walking in the forest. We have a lot of forest, and this 188,000 lakes.
Bueno, este es el final de la primera parte. Ese es mi nieto en medio del bosque finlandés. Tenemos más de 100.000 entre lagos y lagunas en Finlandia.
Excelente. Muchas gracias, doctor Juhani. Excelente conferencia. Unos tips extraordinarios del ultrasonido de hombro, ¿no? Con varios tips de la técnica, enfatizando en el impingement, diferenciando la synovitis, etcétera, ¿no? Excelente. Thank you very much, Dr. Juhani. Great conference. Excellent tips. Excellent tips in ultrasound. Se ha visto todos los videos y todo está excelente, Jesús. Gracias.
Perfecto. Entonces hacemos una pausa de 15 minutos y ya las preguntas vienen en la parte final. ¿Es así?
En la parte final, sí. Una pausa de 15 minutos y retornamos con la siguiente conferencia. Gracias.
Gracias.
Señor.
Que es ultrasonido de codo, anatomía, técnica y qué es lo que debemos, los tips más importantes.
Latitanza ora la capare che un'arpa anatomia e ultrani. Anche altro. Okay. ¿Quieres empezar ya? ¿Empezamos?
Sí, empezamos ya. Sí, gracias.
Okay. Welcome back. We go a little bit down. That means elbow from shoulder. I try to share this.
Share screen, please.
Yes. And then what could be this? No. Lounge? No.
Okay.
No.
No,
Other person. Here. Day one. This.
No.
Elbow.
César, ¿nos avisas cuando aparezca la pantalla en forma óptima? ¿Apareció?
Okay.
Sí, ahí apareció en forma óptima.
¿Yo?
And now this summer.
Excelente.
Okay.
No problem.
9. Sit then. Duo.
Okay, very good.
No, once again, this. Summer.
Pantalla completa.
Nine. Yes.
Okay.
Okay.
Very good.
And now it's good, right?
¿Se ve bien todo? ¿La pantalla llena con la diapositiva?
Se ve excelente y se escucha
Very
perfecto.
good.
Perfecto.
So we go on with the elbow. So in this small cartoon, you see here the point, red point. This is Mikkeli, where we live in with Antonio and I, Finland. 1,100 kilometers long. This kind of on the map. Okay, This is our flag. Okay, let's go on. Learning objectives, I skip that. Well, elbow joint is quite accessible for clinical examination, and usually we use radiographs as a first imaging method. But with radiographs, we only can see the bony surfaces. For example, like OA, like as in this image. So we would like to scan and depict also soft tissues, and ultrasound is very good for that. What can we depict with ultrasound? Normal structures, bony contours, joint recesses, muscle, tendons, vessels, ligaments, nerves, all the relevant nerves. Cartilage, not very well. I have put that in parentheses because the weight-bearing cartilage is hidden. Pathology, we can see bony contours, fractures. Well, X-ray is for fractures, but anyway, osteophytes, erosions, loose bodies, synovitis in case of rheumatoid arthritis, and these tendinopathies we can depict well. Olecranon bursitis, enthesopathies, ligament and muscle ruptures, and nerve entrapments. So a lot of things we can do with ultrasound. Here in this simplified image, I just have put some typical scanning scans, like anterior longitudinal scans, transverse scans, posterior longitudinal scan, which is probably the most important scan for rheumatologists, because here you can the most easiest depict synovitis. We have lateral longitudinal scan and medial longitudinal scans. We will see all these scans a little bit later. Let's start with the posterior scan. Just like I said, this is one of the best, especially for rheumatologists, because you can in a second depict synovitis. How? You put the transducer like this in orange box in real life here. You can see olecranon and humerus, olecranon and humerus, this fossa olecrani, this space here. Normally, fossa olecrani is filled with fat. Then we see the triceps muscle and the tendon and its attachment. The joint space is here, and if there is fluid, it comes through the joint space and lifts the fossa olecrani fat, as we will see. In case of synovitis, you see here anechoic or mixed echogenic material, and this fat is displayed by synovitis. Doppler shows the circulation of this tissue. In this video, I hope it starts. You can see some color movements, but actually it will not start. Anyway, this is the relevant.
Okay.
Yes, no, it doesn't.
Okay.
The relevant message is here in you see Doppler with and some proliferative changes. Sensitivity of ultrasound in detecting effusion is very good. this was already examined by the Meissner in the 90s. It was a cadaver study. They depicted cadavers with X-ray, ultrasound, MRI. They put artificially fluid into the elbow joint, and ultrasound could identify 1 milliliter to 3 milliliter of fluid in elbow. So, and according to this investigation, they also said that fluid collections can best be detected in the fossa olecrani. And of course, the elbow is also always flexed. We can also depict this olecranon fossa using transverse scan, but however, it does not give very much extra. We only can see medial epicondyle, lateral epicondyle, and the cartilage, which is black here, and the fat in olecranon fossa. Triceps, brachii muscle above it. If we depict the joint, we can use also anterior longitudinal view. And now here on the radial side, with this orange box shows you how the transducer is placed. Using this scanning method, you can see radial head, capitellum, and radial fossa. Above these bony structures, you can find brachioradialis. It is there are two muscles on the ulnar side, brachialis, and on the radial side, brachioradialis. So it's easy to remember on the radial side, brachioradialis. And now, in case of synovitis, using this anterior longitudinal view, when there is fluid, the capsule will and a bone will be the distance will be longer, and joint space is widening, as here especially. Again, using this approach of transducer. Now we move the transducer on the ulnar side. Here we see the coronoid recess, fossa coronoidea, also to say. We see trochlea, and on, as I said, on the ulnar side, we have the brachialis muscle on the joint. In case of synovitis and fluid, the accumulation is here in fossa coronoidea. It's lifting, the fluid is lifting the capsule outwards. Dynamic examination helps in detecting small effusion, like this. Just mild flexion of the elbow, and there is some movement. Normally, this there is no movement when the situation is normal. Now we use the transverse scan. Depicting synovitis, this is not so important. But if you depict other structures, we will come on that later. This transverse scan is important because we see the nerves, radial, medial nerve, median nerve, brachial artery, and vein. So, of course, you see the capitellum and the trochlea here, and above it the cartilage. But as I said, depicting synovitis, that's not, I think this is not so important. Then we go to the lateral side of the elbow. There we can find C-toe, common extensor tendon origin. This is important in everyday medicine because people have problems. Epicondylitis lateralis, tennis elbow is related here. Many extensor muscles like fingers, extensor carpi radialis, brevis, and longus, they are the origin of these extensors is here. We can see in tendons inflammation. When tendon is inflamed, it's hypoechoic and it gets swollen with Doppler signals. There might be in chronic cases calcifications. There might be tears, which is anechoic clefts. I can show you examples, or even full thickness tears. There's discontinuity, just like in shoulder. Now we have here the lateral epicondylite, typical, a little bit swollen tendon with a lot of circulation here. Typical active lateral epicondylitis, tennis elbow. The corresponding transducer. Always before scanning, you can feel first with your finger where is the epicondylus, and then just place the transducer there, and you can find it. Once again, one example of lateral epicondylitis. Swollen tendon, hypoechoic with Doppler signals. This is probably status post, so chronic case, not much swelling, but some calcification inside the tendon. In this case, you see here clear clefts. This is a case that the clinical anamnesis is exactly the same than in tennis elbow, but ultrasound image shows rupture, partial rupture in this area, in longitudinal and in transverse. It's quite easy to find this, and the treatment is totally different than in inflammation. So probably you do not make anything, just wait that it will heal. On the medial side, we have the medial epicondyle. There are the site of common flexors. It is the attachment on medial epicondyle. Under that is the site of insertion of tendon. We will come on that later. Medial epicondylitis, again the same, anechoic swollen tendon with Doppler signals in case of active tendinitis. Now, triceps tendon and the insertion to olecranon. This is the normal case. And in case of inflammation, hypoechoic area in the insertion in grayscale. And if you put the Doppler imaging on, you will find increased vasculature showing inflammation. Something else can be found also inside the tendon, like here, calcium pyrophosphate depositions. So ultrasound cannot differentiate this, but you have to put needle and take a sample. This could be gout too, but I have put here calcium pyrophosphate depositions because I have taken sample. But gout is very much the same. How about the distal end or biceps tendon, or we first biceps tendon? It's easy to palpate and just put the probe on the tendon and try to follow it. It's not easy to follow it because it's oblique structure, and especially it's superficial, but finally it goes very deep and oblique. If you try to scan it, you easily lose the because you have to put in full extension, full pronation if you want to see the attachment to the bone radius. But this is not easy, and especially in only can be seen in thin persons. There are some tricks to examine this insertion here, the distal end. For example, placing the, for example here, placing the probe on the posterior side between ulna and radius. It's quite tricky because, and then you rotate passively or actively the hand, and you can see how the biceps tendon comes out here. This is the insertion of the distal end of biceps. Placing the probe like that, it seems not possible, but really it is. It comes when you rotate the hand, pronation, supination. You can see in full pronation, in full supination, you can see how it comes in the dorsal side. It goes really between the bones. There are also other tricks, but this is one to see the very end. But this is not quite common in rheumatology. Probably in radiology, they see more cases, pathological cases related to distal biceps tendon pathology. Very common in rheumatology is olecranon bursitis. This is bursa very close under the skin, and if there is only mild bursitis, it is important not to push. You never should push with the probe. Use a lot of gel, but don't push. You miss this. You compress this phenomenon. You see the fluid under the skin. In case of chronic case, you might see Doppler inside the bursa. Also, gout can be found in the bursa here, and you see the needle is inside to get a sample and to verify that this is really gout. It's only in dark shades you cannot say for certain, because look, this is Staphylococcus bursitis. Okay, it doesn't work. Funny. Yesterday morning it worked, but it only showed that this area here, you can compress it. Compression is a sign that you can verify that something is liquid, fluid. If you can compress it, it is the definition of fluid. You can replace and compress something. But as you see, this is also in gray shades. But the clinical case was different. Patient had fever, and if you put the needle, you can get buzz. But as you see, we cannot quite differentiate with ultrasound and say that this is something. You have to take a sample and take a culture or put it on the microscope. Rheumatoid nodule is a typical clinical presentation. We know that the patient has rheumatoid arthritis, and it's in typical places, in dorsal aspects of the joint. And corresponding ultrasound image here. And now I think we go to the nerves, median nerve. As I said, you can find it using transverse scan at the level of the joint in anterior aspect, and you can find it close to the artery, the median nerve. And when I scan, you can scan it starting putting the probe transverse close to the at the insertion of pronator teres, pronator muscle, and interesting, this doesn't work too. I just want to show that it is possible to follow it when it goes under the we could try once again. Wait. Says that it cannot find this. Sorry. Well, anyway.
Esos videos no están corriendo.
Yeah, the video doesn't work. Okay, let's get back. But it was pity. It worked in the morning. Now I have to make again these my tricks here. Sorry.
Okay.
We go on very soon.
Cecitar, ¿está llegando bien la señal?
Sí, está llegando bien la señal, sino que algunos videos no corren.
Yeah.
Algunos videos.
Sí, claro, hay problemas técnicos. Sí. En la mañana él probó y estaba funcionando normal.
Some videos work, but
pero no hay problema, se ve bien, no hay por qué continúe.
Olemme ongelma, se on näkyy hyvin ja se
yeah.
No problem. Continue, please, doctor.
Okay.
Thank you.
Well, then we go to the ulnar nerve. Ulnar nerve can be found in the cubital tunnel. It goes there. There is a place you can get the nerve entrapped. There is so-called Osborne fascia or Osborne ligament, and it goes also flexor carpi ulnaris between the heads of these tendons. And if the nerve is entrapped, it will grow more than 9 square millimeters. We depict the ulnar nerve placing the probe between coracoid and medial epicondyle, like this. There is 80 megahertz probe, play this in transverse and in longitudinal way. And the corresponding images, here is the nerve. Above it, Osborne ligament, and under this nerve, you can see collateral ligament, medial collateral ligament. And it is not surprising that this nerve can get compressed between the ligament and this medial collateral ligament. In carpal tunnel syndrome, as I said, the nerve is enlarged more than 9 square millimeters, like here. So it's before the entrapment, it is enlarged, and then it gets thin. Also, we can examine the luxation of this nerve in the cubital tunnel, placing the probe between olecranon and medial epicondyle, and then flexing the hand. The probe is kept here, and then we flexed and extend, flexed, extend, and we can see how the nerve jumps over the medial epicondyle, like here. It can be found in full flexion here. So it jumps over. This is the jumping nerve is can be very often found in normal persons too, but it might cause problems for this if they, for example, practice gymnastics or something like that. So this is the only imaging method you can make dynamic examination. MRI cannot tell this. It can say that there's something swelling in the nerve or something like that, but it cannot show this dynamic feature of this phenomenon. I hope this next slide could work because video could work. We see here the radial nerve. The radial nerve comes, as we know, from the back of the shoulder, and it comes here, and then it divides with the sensory branch going to the hand, dorsal hand, and then it divides here at the level of cubital level, posterior interosseous nerves, and this nerve goes through supinator. Let's see if it works. No, it doesn't work. That was a really pity. I could show here how the nerve goes through supinator muscle. And that is the site where the radial nerve entrapment happens. It is at the level of this. Often this can be mixed with tennis elbow because it's quite close to the that area. No, it does not work. Okay, so this is the area, the so-called supinator syndrome, radial tunnel syndrome. This is very difficult to examine with any imaging or EMG. They don't tell much. But with ultrasound, you can exactly show the area of pain. You can show with your finger this area, you can find it. And sometimes you can see that the nerve is enlarged in this area, but not always, but you can see, but if you palpate this area with your finger, you can see, you can understand that this must be the site of the pain. The patient might also have some radial feelings when you compress this area. Now let's talk about a little bit collateral ligaments. And start with the medial collateral ligament. We have the, as I said earlier, we have the so-called golfer's area, the common flexors that attach to the medial epicondyle. Under that, we see the collateral ligament. So-called anterior part is this part here. And especially in basketball players, this area can get broken. Probably in, I don't know, in Peru, do you practice this basketball? But no, not basketball. What is this?
Yes, no, in Peru is not common, this
sport.
sport, yeah.
It's not basketball, it's baseball.
Baseball, no.
Baseball. Yeah. Well, baseball. So in case of damage, you can see disruption of the tendon and fluid and swelling. Okay. Then we already saw this image when I showed the ulnar nerve, and above it is the osborne ligament, and under the nerve is the collateral ligament, so-called posterior part of the collateral ligament here. It is anatomically this area. So it forms the cubital groove. It's the bottom, the floor. The floor, no, the floor is bone, but on the floor is this ligament. Now we move to the lateral side. We see the important ligament, collateral ligament, radial collateral ligament here. The anatomical image. With ultrasound, we can see different parts of this ligament. We can see RCL, radial collateral ligament, attaching to the lateral epicondyle and then to the head of radius. Head of radius, epicondyle, and it is here. This part, it's under the C-toe. This is under the C-toe, as we already, the tennis elbow side is above it, and under the common extensor tendons are these radial collateral ligament, and the transducer is a little bit more down than depicting the tennis elbow. You shift a little bit more down. Then you can depict this lateral ulnar collateral ligament, placing the transducer even more down. It connects the lateral epicondyle to ulnar. And finally, we have also this annular ligament, which is the part of the collateral ligament from head of radius to ulna, this one, finally. And here's the corresponding transducer image and the corresponding image of using a skeleton model. And this is the case of annular ligament. It is very well seen with ultrasound, this fibrillar structure of that ligament. Collateral ligament, the part of the collateral ligament system, annular ligament. Here I have a own case of total rupture of this radial collateral ligament. And to depict this, we have two minor indications. We see first fluid, but not the ligament itself. There is fluid, and this CITO, common extensor tendon, is also ruptured. You see, it's not attached to the bone. And when I now do the varus stress with my, you see how these bones are separating. Oh no, this is, we have to make something when we are, if we have.
For tomorrow, we are going to make the corrections with the computer advisor.
Okay,
So
okay,
tomorrow,
no,
yeah.
yes, but probably we could move the inside the computer. It doesn't work.
There is some,
yeah, okay.
Features that we have
well,
to change.
when I make a varus stress, these bones are separating. So this is the rupture of radial collateral ligament.
Okay.
And finally, loose bodies can also be found. Very often when you see structures like this, you don't quite know, are they attached to the bone or are they loose? How can you say that? Just moving with your moving your probe or hand or making some dynamic to. Okay, thank you. So if you move your patient or the hand, you see that these are not fixed. But in case that this, for example, this is fixed, it doesn't move freely here. So this is a very good way to always to try to examine. Is it osteophyte like here, or is it does it move freely? Okay, I see that this is end of this.
Thank you very much.
De la segunda parte, qué pena que los videos que eran altamente demostrativos, tenemos algunos problemas técnicos, vamos a tratar de corregirlo para mañana.
Perfecto.
Yo cuando hice los test previos, también funcionó muy bien los videos, no sé,
sí.
Sorpresivamente.
Sí, son cosas impredecibles, no hay problema, pero la conferencia excelente, ¿no? Excelente. De repente los videos más demostrativos para evaluar la porción lateral, ¿no? Con la evaluación del ligamento radial, etcétera, ¿no? Que excelentemente lo ha demostrado el doctor. Muy bien, entonces, ¿hacemos una pausa de 15 minutos o seguimos, Jesús?
Would you like to continue or would you like to make a break?
For me the same.
Para Johannes lo mismo. ¿Ustedes quieren continuar? O sea, ¿ustedes
¿no?
creen?
Sí, yo creo que continuamos para y al final hacemos una pausa y luego nos preparamos para las preguntas.
Probably we could take away this.
Vamos a intentar
10 minutes.
Yes. 5 a 10 minutos vamos a intentar a ver si podemos corregir ese defecto los videos. ¿Te parece bien, César?
Perfecto, perfecto, excelente. Gracias, los esperamos. Un receso de 15 minutos nuevamente, por favor, esperamos. Gracias.
Ok, perfecto.
Vamos a continuar con la tercera presentación del día, ¿no? Las dos primeras excelentes. Y ahora es un tema importante, cadera y rodilla, ¿no? La anatomía y técnica y qué es lo que nosotros necesitamos aprender, ¿no? Entonces, continue, Dr. Juhani. Thank you very much for your lectures.
Oh, thank you very much. And now we have a look at the hip and knee, the third lesson. I put this away.
Yeah.
Like that. Okay. And now this is the logo of our hospital. Anyway. Okay. Okay. Hip joint is very difficult to examine clinically. And for example, when I started rheumatology in the 80s, it was before that you could never diagnose, or very seldom diagnose, this synovitis of the hip joint. But hip joint ultrasound came in late 70s and also to Finland in early 80s. And ultrasound of the hip joint is very, very helpful because, of course, the patient might have pain, but I found very early in my research in the 80s that very many patients with hip joint synovitis, they didn't have pain. 1/3 had no pain at all in chronic synovitis, because it is for patients, it's very difficult to analyze pain in the hip area. It's somewhere they can't say always that it's hip, but doctors might find and make the diagnosis very sensitive doing internal and external rotation. Especially internal rotation is diminished at that area where that joint where the synovitis is, compared to the other side. Okay, in children, limping is one leading symptom for hip joint synovitis. Children have this transient synovitis. It's the most common synovitis in children, and then ultrasound is very helpful in guiding injections. In this course, we don't have a title of guiding injection with ultrasound. This is more basic type lectures, but it's very helpful. You can inject hip joint using blind injection, but the accuracy is 40 to 75%. With ultrasound, it is 99% accurate. It's very accurate. Okay. Again, advertising this Euler, you can study that and to see also hip abnormalities, what you can find with ultrasound. I don't read these because we will show them in a few minutes. If we take ultrasound of the hip joint as a region, it's extremely difficult and vast area. We have medial hip so-called adductor system. That's more for sport medicine doctors. And then we have the anterior hip, the coxofemoral pathology, and the lateral hip. The site, very common for patients with pain. And earlier it was called trochanter bursitis, but that's a misnomer. It's a misnomer. Usually we find bursitis very rarely at that area. It is more better to just call it greater trochanter pain syndrome. Greater trochanter pain, because real bursitis is quite uncommon. Then we have the posterior hip, sacroiliac joint, the rotators behind the hip, and the hamstring. They are more for sport medicines. So in this lesson, I concentrate, because we don't have too much time, for anterior hip, coxofemoral pathology, and lateral hip. Just to mention that sacroiliac joint, there is not very much help from ultrasound. You can focus, you can locate your joint with ultrasound. This is sacroiliac joint, but diagnosis of sacroiliitis is as far as I'm concerned, it's very difficult and even impossible. We have MRI for that, for sacroiliac joint. So if we depict anterior longitudinal oblique scan of the hip joint, the patient is put supine position, heels are together, the hips externally rotated a little bit. And the probe is placed in the direction of the femoral column, like here. Because the joint is located quite deep, we need not very high frequency transducers. We choose more low frequency transducers, 10, let's say 10 or something like that. We choose curvilinear or virtual convex probes instead of linear probes. So you have a more widened view to depict. This is scanning with ultrasound, and the corresponding anatomic image, as you see, it's surprisingly the same. It's very much the same. The prominent structure above the femur is Ilio femoral ligament. This is one of the strongest ligament in human body, and it is attached to acetabulum and until the neck of femur, and this is quite loose, so fluid can accumulate here into the joint. We see muscles under the fat, sartorius, iliopsoas, rectus femoris, and it is possible to follow these muscles to their insertion if you want, but now we don't look at that. But what we see in this image, we see it as a acetabulum with a rounded bony surface of femur, the head and the neck. And then we see the in this case it's the joint is almost filled with this iliofemoral ligament, and probably the joint. I don't think if you see, but the joint cleft is here on the bottom of the ligament. The placement of the legs is important. As I said, outward rotation, not inward, because if you put inward rotation, it resembles synovitis, like in this video. Now is inverse rotation. You see, it's an outward rotation. So I recommend to put the legs like this. This is in most people happens, but not in all people. But the recommendation for examining hip joint is to put the feet like this, outward. So, what are the features of normal hip joint? First, the iliofemoral ligament goes along the bone. It's concave, or sometimes a little bit straight, but never convex. It's concave. Usually, both hips are very much the same, only 1 millimeter difference. Then, in normal dry joint, you can see so-called stripe sign. It's a white line under the iliofemoral ligament. And that means that it's empty, it's dry. It is the space between the anterior and posterior layer of the joint. And if you measure between bone and iliofemoral ligament, it's 7 millimeters or less usually, but I will come on this later. And usually the joint is hyperechoic. The joint space, I mean this space between the bone and ligament, the bone and the ligament. This is taken from Simon Robben, who found in the 90s this stripe sign, which is quite helpful. If you find this white line here, it means that the joint is dry. Okay. With new technology and better machines, we can usually easily see this joint space, especially using this harmonic imaging or speckled reduction imaging filter. So you can see this joint cleft here. So what are the features for hip joint pathology, anterior hip joint pathology? First, you see anechoic unilateral space. Here on the left, there is clearly fluid compared to the right side. And then in case of effusion, synovitis, you see convex ligament, capsular distension. And usually there is remarkable side difference. If you compare the right and left here in the upper panel images, you see that there is clearly difference between this. And then if you measure, it's usually more than 7 millimeters. But and you don't see the stripe sign in case of effusion. So you have qualitative and quantitative measures here. You have to take all this account, not just measure something, or you have to see with your eyes and make the decision: is it normal or not. In the 80s, the machines were quite bad, as seen here. We only saw something black between bone and this iliofemoral ligament. So we measured, and there was different studies. I got 7 millimeters, someone got 8, and Dr. Sada got 9 millimeters. So this is only one thing you have to take into account measuring. Usually in normal people, the distance between capsule and it behaves something like this. It's about between 3 and 7, but there are people that are the distance is more. There is one study by Irma Soini. They examined the relationship between MRI and ultrasound, and if you raise these, if you take this measurement as a limit of 7 millimeters, you can get high sensitivity but low specificity. If you raise the cutting value, the sensitivity goes down, specificity up. So the interclass correlation was quite good anyway, but this was selected material. I have talked with the authors. This was not quite nice. They took only subjects, patient who had unclear ultrasound finding. So anyway, we have to take into account as a summary many kinds of things to see is it normal or not normal. If you find effusion, notice that this is non-specific. You have to take into account the clinical situation. Is the patient rheumatoid? Does he or she have a fever, trauma? Also, osteoarthritis is related with effusion very often. And in children, you might have transient synovitis, but also this Legg-Perthes disease and so on. Even in hematologic disease or transient osteoporosis or osteonecrosis, you might have effusion. So you must take into account the clinical picture and what it could be, the reason of this effusion. Ultrasound is very good in depicting also osteophytes, and as you know, X-ray only takes into account these lateral osteophytes, but with ultrasound we see these anterior osteophytes. Quist-Card showed in the article a normal situation, early osteophyte, just a little bit bigger osteophyte and huge osteophytes. So there are different stages. Also, pay attention to the flattening of the head, femoral head. In normal case, it is nice and rounded. In moderate, flattening here, and in case of even this could be even some osteonecrotic or something. We can with ultrasound also pay attention to the bony contour of the neck and head especially. In this dynamic scan video, this side here belongs to this part and this side belongs to this side. So we see in the X-ray, I hope you see that there is more narrowed joint space. Also here is a little bit narrowing of the joint, but in ultrasound image there is clearly difference. If you pay attention that here is synovitis, proliferation, and fluid, and then pay attention of the not so nice rounded head of the femur, and there is no, in this video, I will run it in a minute, in a second, there is no cartilage. And what I do here is I move the transducer a few centimeters from medial to lateral in this video. The transducer is here, and I make a little movement from medial to lateral. So, as you see, there's a huge proliferation, and it's not so. Once again, it's not so rounded, and there is no that no cartilage compared to the other side. It's much more nice. There is a little bit cartilage here, and there is no synovitis, right? So there you see here the cartilage, nice rounded head. So with ultrasound, you can also try to examine these bony contours of the femur. As I said, bursitis is very rare. What we can see, sometimes iliopsoas bursitis, also called iliopectineal bursitis, and this trochanter bursitis is also quite rare. In this case, you see synovitis in a hip joint and iliopsoas bursitis. Here is a huge synovitis bulging of the, and here you see proximal to the joint there is iliopectineal bursitis, probably connection to the joint usually can be seen. Lateral hip joint, greater trochanter pain syndrome. As I said, we have the muscles. We have the most superficial muscle covering is gluteus maximus, and under that is gluteus medius and then gluteus minimus. Gluteus minimus is attaching to the anterior facet of the trochanter. Gluteus medius is more attached to the superior posterior flateral aspect here. So, and gluteus maximus is not attached to the trochanter; it's more attached to the femur down, but it's always the most superficial. Here we can see gluteus medial insertitis. You see the bony proliferation here, and then thickening of the tendon with Doppler signal. Doppler signal is not common; it's uncommon finding. Lateral hip, normally you can see skin, fat. As I said, gluteus maximus is the most superficial muscle. Under that, gluteus medius. And what we can see usually is calcification and bony profile changing here. And this kind of bursitis, which is here, subgluteus maximus bursitis, it's uncommon. There are several bursitis under each muscle. Subgluteus medius, subgluteus minimus, and so on. Ultrasound findings and enthesopathy are very common in patients and normal people. Gutierrez made a study in 46 spondyloarthropathy patients and healthy age and sex matched controls. What was the result? Patient had 40% enthesopathy at this area, but controls had 30%. So it's very common. And you have to understand that imaging findings and symptoms don't match always. For example, there are MRI studies that have shown that they are it's very common finding to have insertitis enthesopathy findings in healthy people. So imaging is quite problematic in this area of greater trochanter pain. This is very busy, but let's go very rapidly. So we have is useful in septic arthritis, ultrasound, inflammatory arthritis, bursitis, greater trochanter pain syndrome. Well, anyway, it's 2+. Well, 1+ is enough. Inguinal hernia, sport hernia. This is not case in rheumatology. Thrombosis, lymphadenopathy. It's very helpful in children, transient synovitis, and so on. And congenital dysplasia of the newborn. I have never had this patient because I'm not pediatric, but this was the first application of musculoskeletal ultrasound in the 70s. The newborn congenital dysplasia. Anyway, tendon muscle problems, very helpful. Meralgia paresthetica, if you see the nerve. In OA, in femoral acetabular impingement, it is the finding that can be found in the resembles very much the osteophyte. Anyway, snapping hip, it can be useful, showing this is it psoas muscle or is it snapping around trochanter and so on. Fractures, of course, we use X-rays, but ultrasound can be useful in that too. Labral tears, this is not for ultrasound, this is for MRI. Hip pain after arthroplasty, that's quite an useful in many cases of arthroplasty, not only in hip area, because if you find effusion, it is a sign of infection or loosening. So sacroiliacal pain, it is not useful. Evaluation of cartilage, not very useful because actually we are interested inside the hip joint. We don't see the weight bearing cartilage. Tumors, well, no. Spinal nerve problems, no. But anyway, ultrasound is in many cases useful. We move to the next topic, which is knee joint.
Excellent, thank you.
Okay, to the knee joint. Ultrasound can be performed using 15 megahertz and again linear probe. We use linear probes in rheumatology. We depict in long axis suprapatellar bursa area, transverse. We can go knee flex over and beside the patella, depicting cartilage. I will show it. We can depict patellar tendon under the knee joint, transverse, longitudinal, medial and lateral, longitudinal, transverse, and of course the posterior area. And again, Euler ultrasound scanning app, advertising of that. A lot of abnormalities can be found. I will not read this. we can see these in next slides. I highlight that ultrasound is not good in evaluation of internal bony lesions. So we cannot see inside the bone. We cannot make reliable meniscal diagnosis. We can see the superficial part of the menisci, but not inside deep into the and cruciate ligaments. Also, this is the area for MRI to depict that. So, but anyway, with ultrasound, you can do a very much valuable diagnostics, I think, and it is very helpful for radiologists and especially for rheumatologists in this case, as a tool to extend your clinical skills. First, we make the normal anterior suprapatellar imaging. What we see quadriceps tendon attaching to the patella superior pole. We see under this the peripursal fat and the suprapatellar pursa. Then we see a normal, a little bit fluid in normal human beings. And it is important to put something under the knee and flex the knee about 30 degrees. Why? Because it has been shown by Peter Mandel and colleagues that if you put 30 degrees flexion, the most fluid is collected. So it's the most easiest to see fluid in the suprapatellar pursa, and also to aspirate and inject using blind techniques or ultrasound techniques when you put something and flex the knee. Then we go down to the infrapatellar area, longitudinal scan. We can see patellar ligament and Hoffa fat pad, as here also the corresponding anatomical image. On the medial side, we can see meniscus, and these two layers of collateral ligaments. There is a short layer attaching to the meniscus and longer layer, which is, we can follow it until the pes anserina. Is the longitudinal view. As I said, we cannot make a real diagnosis of meniscus tears, but we can see if the meniscus has displaced, is there protrusion. It is about 4 millimeters. It is the cutting of the normal value. How do we measure it? We make a line between the bones, femur and tibia, and make the measurement from that line under osteophytes. So in this case, 4.8 millimeters. So it's too much. There is some protrusion. What does it mean? It means that it is a sign of OA or tear when it comes too much protruding. So in this case, in the lower right panel here, you can see also a clear cleft is the meniscus rupture in the superficial part of the meniscus. It is possible to depict there on this superficial part.
Mm.
Lateral knee, what we see? We see again this meniscus, and then we see the bones, and what we see here, the popliteal area, the popliteal tendon. Popliteus is a tendon that goes intra-articular, but it is extra synovial structure, so they say. And then we see when we put the transducer like this and a little bit put the distal part down, we can follow the collateral ligament, lateral collateral ligament structure here, corresponding anatomic image here. This is it. So these are the lateral structure, but also one is missing, the iliotibial band, which is the most upper fibrillar structure coming from, so as it says, ilio, from ilium to just stabilizing one of the lateral stabilizing structure of the body. And sometimes we can see insertitis at this area, but it's quite uncommon. But it's quite easy to depict this band. And the effusion and synovitis itself. So this is very much the same, unechoic fluid, which is without these proliferations, and rheumatoid synovitis villus is typical bushy structures, echoic structures. Like here, we can see clearly. I'm compressing with my transducer these structures. So what is fat? Fat is also intra-articular articular structure. Is typically round and homogeneous. It's soft, fixed, but usually it does not exhibit Doppler. But you can many times see these kind of structures, and sometimes it's not easy. It's not easy to say that this is synovitis, this is fat, but fat resembles like this: round, homogeneous, and soft, and does not. So this is more likely to be fat. Here is an example of effusion, black effusion here, and Doppler signal, and the synovium is thickened here, and normally you don't see anything like this in normal human being. You can easily say that there is a chronic synovitis at this level where the transducer is now. And here you can see an extreme proliferation filled in a knee joint. You see this villus formation here. It's knotty, chronic with extreme Doppler signals and proliferation. This is untreated, not well treated person. And tendonitis, we see here quadriceps tendon on a healthy side, attaching to the upper pole of the patella, but on the other side, where is the painful side, and when I placed the hand here, it was I felt warm skin, and this is clearly thickened in a young patient with spondyloarthritis. And with corresponding transducer placement. Very often you can see tendon calcifications on the patellar side here, or in the quadriceps. These are very often seen in middle-aged persons, and these are very often they don't have any pain or this is but just to show that this kind of finding is possible. Then bursitis can be prepatellar. It's just under the skin. Usually we don't even we hardly can see it depicted. It's there, very small space. But if there is some fluid and inflammation, you can find it with ultrasound. This bursitis. And when we go down, we can see the superficial infrapatellar bursitis. So this is superficial infrapatellar bursitis. This is under the patella. And the corresponding transducer position is shown here on the lower right. Enthesitis, this is normal case, about 4 millimeter tendon, and this is anisotropia because the patellar tendon is oblique. This is typical anisotropia, not tendinitis. But on the right side, you can see clearly thickened tendon with huge Doppler signal and even erosion in the patellar area in a person with spondyloarthropathy. Another case of enthesitis, active case where there is a thickened tendon and with Doppler signals, but on the other knee there was no pain, but as a sign of older inflammation, you see calcification in the tendon. So thick calcification that the ultrasound beam does not go through it, and there's acoustic shadowing here. We go distal, insertion of patella. Normally we can see the bursa, deep intrapatellar bursa, which is here too much enlarged. We can call it bursitis, but usually we can see a little bit fluid under the in the bursa. And in case of chronic situation, there is proliferation and Doppler activity in the bursa. This is transverse view, so it's under the patellar tendon here, and under that is the bursa with chronic inflammation. Again, one example of patellar enthesopathy. In this case, we can call it enthesitis because it's a patient with spondyloarthropathy. So enthesopathy is a large phenomenon. It's everything what is inflamed. Enthesis is enthesopathy, but enthesitis we mean only patients with spondyloarthropathy. Sometimes you can find on medial side cyst, meniscal cyst, and then we have this pars anserina area, which is the insertion of gracilis, sartorius, and semitendinosus, this area. And in this case, there is even with your eyes, you can see swelling in this area, and the corresponding ultrasound image chronic inflammation with Doppler signals. This is very nice to inject under the ultrasound guidance. And this patient was cured with one nice injection of glucocorticoid. Then we go on the posterior side, and there is the famous Baker's cyst. Baker's cyst was the first musculoskeletal phenomenon that was published in 1972 by MacDonald and fellow. It was the first publication of musculoskeletal area. So they could differentiate it from the deep venous thrombosis, this Baker's. So, and as we know, it's very common finding. And what is Baker's cyst? It's a cyst between gastrocnemius and semimembranosus. So you might think that you cannot clearly see this, and it is because there is anisotropy. This semimembranosus tendon and muscle, it goes a little bit in different direction than gastrocnemius. So that's why it's very often difficult to get them clearly in the same image. How do I find this? My target and my first, what I want to see, find is cartilage, medial femoral cartilage. The patient is put in prone position, and I try to find medial cartilage. Then very close to that, you see this pullet-like structure, gastrocnemius, when it makes this kind of figure. And then I see the semimembranosus, which has a very small tendon, and it grows very rapidly as a muscle. Then we have a semitendinosus tendon above it. It has a very long tendon. It turns into muscle in the middle of femur almost. And this bursa is between gastrocnemius, semimembranosus, coming from the joint. This is the bursa. Gracilis is more medial here. Baker's cyst, as we know, very often will rupture, and it is sometimes very large, extending until the ankle joint even. In this case, 16 centimeters long. It goes under the skin between the muscles. It can be ruptured very, very clearly. You can find it very close to the knee joint too, in patients with rheumatoid. And in this case, it is very common that they come to the emergency room. Very often, doctors believe that it is because of swollen calf. They think that it's a deep vein thrombosis, but ultrasound can easily reveal the situation. And okay, osteophytes. Ultrasound is very good in detecting osteophytes. We can see normal case. In normal case, the femur and tibia are rounded. But if you have a small, very small osteophyte, you can see these peaks in medial and lateral side. In medium size osteophytes, and very big one, very big one, large. This is not the atlas, but just to show you the different size. And in our studies, it's much more sensitive than X-ray. In our series, if you find osteophytes in 50% with X-ray, you can find 75% osteophytes with ultrasound. So it's very, very, very small, even a few millimeters osteophyte you can find. And what does it mean? It means that the patient has OA. If you have osteoarthritis, that's important to know, because we know that there is a lot of inflammation and so on, and of course pain related to OA. So in differential diagnosis, it is important to know that you have signs of osteoarthritis. So, but what is very funny, that you can sometimes find intra-articular osteophyte too. How can I know that this is osteophyte? As I said it was in elbow, that if you move make dynamic scan, you see that this is fixed. This structure here is fixed to the bone. See, it must be osteophyte. It is not loose body, because it is fixed. How about hyaline cartilage? There are some joints in the human body that is very accessible for ultrasound. Knee joint, because you can flex. You can see the cartilage here, the weight-bearing cartilage. The second one is the MCP joint. You can do the same. There are many, for example, this carpus, you cannot in wrist joint examine cartilage, or even in elbow joint. In shoulder, that's you can try to examine the cartilage, but not very well in hip joint, not good in ankle joints, and so on. But knee joint, that is very, very accessible for ultrasound. And how do we do it? We do it so that we swipe with transducer. The transducer must be all the time perpendicular to the bone. We don't go over the patella. We go beside of the patella, near the patella, medial and lateral. For example, like in this video, we see here nice cartilage in suprapatellar area. Then we go down in the medial condyle, and we see that there is clearly diminishing cartilage. There is narrowing of the cartilage here compared to that area. You see, and how can I know? How can I be sure that this is cartilage damage? Because this patient took part to our study, and he went after that into the operation room, and after 1 hour of that after that ultrasound study, and in arthroscopy it was found that there was a 50% more than 50% cartilage defect. And here is a atlas-like image just to show you how this diminishing of the cartilage goes. We see here stage 1, stage 0, that is normal, nice cartilage on the condyles and in the sulcus area, in intercondylar notch. Then we have some minor changes, and then we have 50% diminishing here, and then we have finally 100% diminishing it is in cases of when the soft tissues is on the bone. So there is total nothing. It's all gone, cartilage. And arthroscopy has shown, for example, arthroscopy and other studies, that there is nice correlation of ultrasound and arthroscopy evaluating medial condyle and lateral condyle and intercondylar notch cartilage of the knee. And don't forget that it's also nice to evaluate muscle thickness in knee joint. We will talk about muscles. I think it was day 3 or 2 more, but sometimes it's nice to see that on the osteoarthritic side, you see this muscle is much more thinner than on the healthy side. So it is nice to recommend the patient to do some exercise on this knee, because it's much more difficult to walk and stand, go on stairs if he has or he or she has weak muscle in the knee with OA. And we will talk about more about crystal deposition diseases, but just to remind you that very typical sign of gout is the so-called double contour. Double contour means that you have bony contour here, but then you have a second white line as thick as the bone. It's double. It seems double compared to the age and sex match healthy male here. You see, you don't see here any double sign, but this is typical for gout. So gout is on the cartilage. But in calcium deposition disease, the deposition is in the cartilage. As you see here, normal, and there is something in the cartilage. This is typical for calcium pyrophosphate deposition. And this is how they differ. So gout is on the cartilage, calcium pyrophosphate is in the cartilage. And also what is important for CPPD, calcium pyrophosphate deposition disease, is the white meniscus, more or less, but there are these typical lesions in meniscus. It can be totally white. So there are depositions in the meniscus. So this is again nice summer. We had a very nice summer last summer, but it's very warm and nice. This is from shore, Finnish on a Finnish lake shore. Nice memories. Hope we see such a nice weather next.
Bueno,
Thank you very much. Thank you very much, Dr. Juhani, for your excellent lectures. It has been an extraordinary morning for us. The extraordinary paysages of Finland and similar of Peru. Thank you very much. Let's continue with questions. Any questions?
Sorry.
Vamos a empezar con algunas preguntas, doctor Santisteban, doctor Juhani.
We're going to start questions.
Yes.
Empezamos por la primera conferencia, la ecografía de hombro, excelente la técnica, pero tenemos muchos residentes ahí en el auditorio. Comentarle al doctor Yuhan, al doctor Santisteban, que hemos tenido en el top 80 participantes, todos atentos, ¿no? Eso es importante para nosotros. Y preguntarle, cuando los residentes empiezan a hacer la ecografía, el artefacto de anisotropía crea dificultades. ¿Cuál sería su consejo para los residentes? Por favor, doctor Santisteban, le traduce al doctor Yuhani.
Yo, elicación general, palio, dama, edicos, balacariola, joka, kun aloitetaan tämä olkapää ultraanitutkimuksessa hänen ajattelee kaikki pahin on anisotropia. Mikä neuvo sinä voi antaa heille tämän anisotropia suhteen, tämä olkapään olkapää tämä?
Well, the importance of anisotropy is that you know this phenomenon. It is always when you have something oblique structure. It is the same in tendons, and you just know that when it's something oblique and the ultrasound beam does not come exactly in 90 degrees, ultrasound cannot detect that. So you just have to, for example, push your transducer a little bit or compress or just have a look in transverse and longitudinal. So this is the what you have to do. And I think if you can easily get familiar with this phenomenon and you can learn it. It's not a bad thing.
Es uno de los grandes retos quizás de la articulación del hombro, o sea, hay que colocarlo el traductor exactamente a 90 grados y a veces hay que comprimir, hacer digamos, jugar con la posibilidad de cambiar a la posición transversa y a la longitudinal. Es realmente todo un reto, ¿no? Pero si se hace sistemáticamente, entonces se puede llegar, digamos, a tener un dominio.
Perfecto. Mientras va preparándose, el doctor Calvo tiene una pregunta.
Sí.
Hay casi un aspecto filosófico que siempre conversamos con nuestros colegas radiólogos, ¿no? Entonces, un tema importante. ¿Cuál es la diferencia entre receso y bursa?
Mikä ero on tämä resesi ja bursa?
Well, the joint recess is the joint itself, and bursa is always between something gliding, for example, between bone and muscle, and between, for example, deltoid muscle. Under that is the bursa. Bursa are important structure because it diminishes the energy. It gives possible that the structures can glide on each other.
Sí.
And if there is an inflammation, there is accumulation of fluid.
O sea,
and joint is of course joint is in the joint, and so it's bursa is not usually connected to the joint, but for example, if we have rotator cuff rupture, total rupture, so there is communication between bursa and joint, and that in that case synovitis and bursitis is actually the same phenomenon because there is connection between the joint. So usually bursa and joint are different, but there is a misnomer. We call it suprapatellar bursa. So it's actually funny because suprapatellar bursa is just the extension of joint in knee joint. That's actually quite funny.
Obviamente el receso es intrínseco a la articulación, la bursa es totalmente independiente, pero en el caso, digamos, en el caso del hombro pueden ser, digamos, intercambiables.
Ujú. Ya. Gracias, gracias, sí. Doctor Calvo, por favor, Omar, ¿le puedes dar el micro al doctor Calvo? Su pregunta, por favor, doctor Calvo.
Gracias, César. Thank you so much for your wonderful lecture, Professor.
Thank you very much.
La pregunta es en relación a que normalmente los reumatólogos, antes de intervenir sobre el hombro, antes de infiltrarlo con corticoides, usualmente tomamos todavía una radiografía del hombro. Y no para evaluar las partes blandas, sino más bien para tener una evidencia de que las estructuras óseas están bien. ¿Usted considera que eso lo pudiésemos reemplazar? Tengo entendido que en Alemania están haciendo eso, por una ecografía, pero que el ecografista, además de revisar todas las partes blandas, tiene que asegurarnos que las partes óseas también están bien. Y con eso pudiésemos nosotros ya proceder a la infiltración y además con una mayor, digamos, certeza de lo que está pasando también.
Ya, me permite hacer la traducción. Son sanotan eta tama perusa, son pitkaika joka rheumatologit karastavat ennen tehdä joku tämä olkapää infiltraatio. Se otetaan natiivirengen kuva, se on arvioida, se on luurakennuksia. Mutta nyt viime aikoina kyllä varmaan tämä on ultranin perusteella. Ajattelevat, että kysymys onko tämä, onko kuinka luotettavaa on se on tämä arvioida pehmeä kudoksia ja myöskin tämä luukudoksia, se on tämä ultranin perusteella.
Okay, so ultrasound is for evaluating soft tissues, yes. And ultrasound can be used for detecting bony contours, so the superficial part. So we can see with ultrasound erosions and osteophytes and so on, even fractures if we want. But usually we use X-rays. But it is the soft tissues that is it's very practical and easy way to visualize soft tissues, inflammations, and so on, ruptures, tendons, muscles, and nerves. So I think X-rays it's only for bones and joints. So it's quite limited value. But of course, if you use together X-rays and ultrasound, for example, for the shoulder, I think it's very, very powerful combination. And in my case, I very seldom use MRI because I have ultrasound and X-ray.
Sí. Doctor Calvo, lo que nosotros hacemos acá es en el caso de la cadera, de la articulación de la cadera, o sea, antes de hacer una infiltración con una guía de ultrasonido, se toma una placa nativa de cadera para evaluar, digamos, el grado de artrosis y ver si es que es viable, digamos, la infiltración. Pero en el caso, digamos, de la articulación del hombro no se estila porque hay suficientes ventanas, una bastante confiabilidad, digamos, en la ruta. Incluso las nuevas máquinas te pueden medir la cantidad de milímetros, la cantidad, digamos, desde el lugar, desde la piel hasta la articulación, ¿no?
Muy bien. Otra inquietud. Hemos visto, por ejemplo, que es importante la evaluación dinámica de las diferentes articulaciones, ¿no? En el hombro, por ejemplo, la evaluación del impingement es fundamental, la evaluación dinámica, igual en el caso de la rodilla, igual en el caso de la cadera, ¿no? Es fundamental. ¿Qué consejos le daría a los residentes respecto a la técnica de la evaluación dinámica de las articulaciones? Jesús, gracias.
Sono sanotaan, että on niin tärkeää, se on tämä joku dynaaminen tämä, se on tämä arbio,
Yeah.
son impeachment sustain, ya mi oskindama, yokutama, son dama. Ja sitten mikä neuvo siinä voi antaa joku erikoistuville radiologille tämä dynaaminen tämä arvioinnin suhteen?
Okay. Yeah, ultrasound is very useful for dynamic examination. It is just different from MRI and X-ray that you can do everything dynamic. And so it's difficult to say, but just practicing. So it is only two-dimensional image, and you just must practice. Learn anatomy from books, learn anatomy, what are the structures, and then you have to find this anatomical structure using books. You can use your own body or a friend's body, but practicing. The learning curve is endless.
Bueno, lo que él aconseja, obviamente, la práctica hace al maestro, ¿no? O sea, practicar, tener conocimientos básicos de anatomía, practicar en 2 dimensiones, y dice de que la curva de aprendizaje es infinita.
Así es, efectivamente, estamos de acuerdo con el doctor. Otro detalle importante es la evaluación Doppler, ¿no? La evaluación Doppler. La escala de grises nos da la morfología de la articulación, de los contornos óseos, etc. ¿Utiliza el Doppler Color o solamente el Doppler Power? Y si utiliza los grados que se ve, que aconsejan...
Perdón, repíteme, si el Doppler simple te refieres, ¿a cuál Doppler,
sí,
perdón?
El Doppler que se utiliza comúnmente es el Doppler Power, ¿no?
¿Ya?
Doppler Potencia también se llama,
Sí.
Power o Potencia. La pregunta es, algunos radiólogos y reumatólogos utilizan el Doppler Color. ¿Utiliza él el Doppler Color o solamente el Doppler Power?
Kumpi siinä kautta eniten, se on Doppler Color tai Power.
Yeah, which is better, color Doppler or power Doppler? It is very difficult to say, because in some machines, color Doppler is better than power Doppler. So it was thought very long time that power Doppler is more sensitive than color Doppler. But in new machines, it is possible that in some machines, color Doppler is better than power Doppler. So you have to test it in your practical work, which is more better. So I think there are some specialists, for example, Thor Pedersen from Denmark, who is a very famous, that thinks that color Doppler is much better anyway, that it will push power Doppler away in future. But anyway, I think it's the most important is to that you can make your machine sensitive for different depicting. It is different values and adjustments are for large vessels, and in rheumatology we use so-called slow flow settings. So for example, there are it's difficult, but let's say 2 values: pulse repetition frequency, PRF, must be about 500, and then you raise your color flow up so that there comes noise, and then raise it down. So this is my, I could talk 1 or 2 hours from this subject. This is only what I tell you now.
Bueno, él dice de que en realidad depende del tipo de ecógrafo. Hay algunas, tradicionalmente, inicialmente el Power Doppler era más sensitivo, pero nuevamente hay muchas ecógrafos donde el Color Doppler es tan sensitivo, y es cuestión de probar y ver el nivel el umbral de sensibilidad de cada una de los ecógrafos, a fin de evaluar, digamos, usando small flow, que es una de las características, ¿no? Pueden, digamos, comparar con, digamos, con los grandes vasos, y hay una serie de propiedades como el pulse repeat frequency, que debería ser de 400, y ir probando y colocando. Y dice que este es un tema para 2 horas respecto, digamos, a los ajustes para el Doppler.
Sí, 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 efectivamente, tiene mucha razón el doctor. Una pregunta que es importante: en los últimos años, Jesús, tenemos una nueva técnica que es la elastografía, ¿no? La elastografía que mide la dureza de los tejidos. ¿Tiene alguna experiencia con elastografía en las articulaciones?
Viime aikoinaan on tullut esille tämä elastografia tekniikana, ja sitten, että onko sinulla kokemuksia elastografia suhteen?
As far as I'm concerned, I don't believe in elastography. Elastography is for radiology, for examining fibrosis of the liver and so on. But I think it has very little to give in musculoskeletal area. Actually, elastography is based on Doppler in one aspect. It's the theory is based on that. And I think what we need is grayscale imaging and Doppler imaging. That's enough. And well, there has been more than 10 years since development of elastography, and even 15, but it has never come famous in musculoskeletal area.
Sí. La elastografía, a pesar de que teóricamente es mejor que el Doppler, no tiene mucha aplicación en lo que es musculoesquelético. Las experiencias son básicamente a nivel de hígado, básicamente detectar, digamos, fibrosis hepática inicial, etcétera, etcétera, ¿no? Pero no tiene experiencia y por lo pronto no encuentra aplicaciones.
Excelente, gracias. Otro tema importante, habiendo los residentes, es, nos ha mostrado unas excelentes imágenes de lo que es la sinovitis, ¿no? La hipertrofia sinovial. Cuando uno encuentra líquido en las articulaciones, un fluido, ¿no? Es importantísimo evaluar la calidad del fluido, ¿no? Esas ecogenicidades, esas formas arborescentes, incluso que se parecen al coliflor, darle el Doppler Power o el Doppler Color, y eso informar, si es un radiólogo, al reumatólogo, o que el reumatólogo revise bien y haga un diagnóstico adecuado. ¿Podrías decirle, por favor, que haga una ampliación más de esa característica fundamental de evaluar el fluido en las articulaciones? Gracias.
Joo, se on tämä joku erikoistuville lääkärille myöskin, tämä synoviitin suhteen. Siellähän on kiinnostunut tämä joku tämä, se on tämä sisältö, eli se on nesteitä, joka on sisällä joku tämä laatu. Laatu, se on quality.
Niin.
Joo, quality. Se on, hän haluaa, että jos joskus on tullut, että jos on hypogeeninen tai anogeeninen, joku sellaisia piirteitä, joka ehdottaa joku etiologia, ja sitten onko sinulla jotakin kriteeriä tällä joku tämä synoviitin ja myöskin tämä effusion suhteen tämä nesteen.
Well, we have when we have a clear fluid, it's anechoic. Fluid is anechoic, and then there is some tricks. If you see something black, and then you see the posterior enhancement after the fluid, after this black area, you can be sure that it is fluid, because acoustic, there is no the beam goes easily through fluid and makes so-called acoustic enhancement after the fluid. So fluid is fluid, and it's something you can displace. Fluid is, you can, I think I will talk about these things later if I remember. So fluid is something you can displace and compress. One exception is that ganglion is often very hard. You cannot compress. Anyway, fluid is something you can fluid. And then if you have something echogenic material, you can never be absolutely sure what that is. But in clinical context, when you see that patient has a rheumatoid and you see expansion of the joint space with echo material there, and with Doppler, you can be sure, almost 100% sure that it's synovitis. But to be honest, we can never say anything with imaging that something is synovitis, that something is gout or something. We have only believed that it is true. So we have echogenic material and we have black material, which is fluid. So everything depends on what is the clinical context, and we can always take, for example, aspiration to see more, to understand more about the phenomenon, what we are depicting.
Lo que sí es seguro es de que es un fluido cuando es anecoico, pero si es que es hipoecoico o isoecoico, realmente las posibilidades, se puede especular mucho, pero no hay algo seguro.
Perfecto, perfecto. ¿Hay algunas preguntas del auditorio, por favor? Levantaron la mano. Muy bien, yo creo que la charla, han sido unas charlas maravillosas, ¿no? Excelente la forma de presentación didáctica, ¿no? Un maestro, el doctor Giuliani. Nuestro agradecimiento, ya para ustedes ya es muy tarde, así que vamos a dar por culminado esta primera sesión. Jesús, nuestras reiteradas gracias, un fuerte abrazo, y el día de mañana vamos a continuar a las 8 en punto de la mañana con las siguientes conferencias. Thank you very much, Dr. Giuliani. See you tomorrow.
De igual manera, nos vemos mañana. Ok, gracias. Muchas gracias a todo el auditorio. Gracias por la participación.
Okay, thank you very much, and we go on tomorrow.
Oh, thank you very much, Dr. Giuliani.
Yeah. Have a nice day there. We have already night almost.
Okay.
So, we go sleep, you go work. Yeah, okay.
Bye-bye.
See you.
Bye-bye, see you.
Bye-bye.